Cockayne syndrome is a rare genetic disorder. There are multiple terms used to refer to this disease, including deafness dwarfism retinal atrophy, Neal-Dingwall syndrome, and simply CS. There are 3 known types of Cockayne syndrome. This video will focus on CSA and CSB, although the third type, xeroderma pigmentosa Cockayne syndrome, shares many similarities. CS is an autosomal recessive disorder. So, if a seemingly healthy couple has a child that is diagnosed with Cockayne syndrome, the recurrence risk is quite high. Those 2 parents must be carriers of the disease, which means there is a 1 in 4 chance that their child will have CS. Next-gen sequencing to test if at-risk relatives are carriers, as well as prenatal testing for a pregnancy at increased risk, and pre-implantation genetic testing are possible if the pathogenic variants in the family are known. This is an exceedingly rare disorder. The incidence is less than 1 case per 300,000 live births in the US, although it is unknown how accurate this estimate really is. Only a couple hundred cases have been reported in literature. Sporadic cases have been identified, but there is no data regarding how frequent this is. Of those that do have CS, about 80% have type B and 20% have type A. CS can result from various different mutations in the CSA and CSB genes, including exon rearrangement, short deletions, and otherwise. There seem to be different mutations in different populations, which may be the results of common founder mutations. However, there have not been any studies suggesting ethnic or racial partiality. Additionally, males and females are affected at the same rate, and the disease shows complete penetrance. At the most basic level, the molecular basis of CS is a loss-of-function mutation in one of the genes involved in DNA repair. CSA involves a mutation in the gene encoding the group 8 excision repair cross-complementing protein, or ERCCA, on chromosome 5, while CSB involves a mutation in the gene encoding the group 6 excision repair cross-complementing protein, ERCC6, on chromosome 10. These excision repair cross-complementing proteins, when functioning normally, play an integral role in the removal of RNA polymerase II in order to recruit additional proteins and initiate farther steps of the nucleotide excision repair or base excision repair process. The ERCC6 protein is specifically involved in the recruitment of histone acetyltransferase core NAIR factors and an E3 ubiquitin ligase complex. The ERCC8 protein is actually a part of this complex and plays a vital role in fostering protein-protein interactions at the RNA pol arrest site. Ultimately, whether it is the ERCC6 or ERCC8 protein that is dysfunctional, the chromatin at the lesion site is unable to be unwound, repair is unable to occur, and prolonged arrest results. Typically, inability to repair damaged DNA leads to accumulation of mutations such as cyclobutane pyrimidine and thymine dimers, and ultimately cancer. Interestingly, there has not been a single report of a CS patient developing cancer. Previous studies have shown that CS cells actually do not accumulate UV-induced mutations any faster than normal cells, and since these individuals have such a short lifespan, there is a low probability of cancer developing before the patient's death. However, despite the similar mutation rate between healthy people and CS patients are far more sensitive to UV exposure and the mutations that do arise. A likely explanation for this involves the prolonged transcription arrest, subsequent p53 activation, and cell death. Studies are ongoing to further investigate this interesting finding with a focus on transcription and apoptosis. Since RNA pol II is stalled at the site of the lesion, if the CS proteins are dysfunctional and unable to remove it, transcription rates would be heavily affected. Transcription arrest is a known driver of apoptotic signaling, and because of this, some researchers are speculating that the ultimate effect of mutated CS genes ERCC8 and ERCC6 is excessive cell death by apoptosis. Cockayne syndrome is a pleiotropic disease and therefore displays a wide array of phenotypes. Cockayne syndrome is a pleiotropic disease and therefore displays a wide array of phenotypes. Effects can include short stature, premature aging, severe photosensitivity, learning delays, failure to thrive, microcephaly, hearing loss, cataracts, tooth decay, and more. Not every patient experiences all these mentioned symptoms, and some patients experience additional symptoms. However, these symptoms can often be used in diagnosis. As previously mentioned, Cockayne syndrome is a pleiotropic disease and therefore displays a wide array of phenotypes. Effects can include short stature, premature aging, severe photosensitivity, learning delays, failure to thrive, microencephaly, hearing loss, cataracts, tooth decay, and more. Not every patient experiences all these mentioned symptoms, and some patients experience additional symptoms. However, these symptoms can be often used in diagnosis. As previously mentioned, CS is a NAIR-related disorder. There are multiple similar NAIR disorders, including xeroderma pigmentosum, trichothiodystrophy, and others. However, CS cells show a specific defect in a NAIR subpathway called transcription-coupled DNA repair. So, a common diagnostic test is based on detection of this specific TCR defect. This is identified by culturing patient fibroblasts and performing a radioactive assay in order to measure the recovery of RNA synthesis after UV radiation exposure. This DNA repair test is a decisive tool for the diagnosis of CS and can be used for prenatal diagnosis as well. Direct molecular sequencing is also used in instances where the causative mutation in the family has already been identified. There's a lot of variability in what these genetic tests focus on, and it depends on the individual case and resources available. Sometimes brain imaging is also utilized, with myelination abnormalities in white matter being indicative of CS. CSA and CSB show similar clinical expressions, but CSB is much more severe, with symptoms presenting from birth. Individuals with CSA often develop symptoms at age 1 or 2. Prognosis for CS is not good. In CSA, the child often has normal development for the first year or two, but then growth slows and developmental delays become significant. Death occurs before age 20, typically between ages 10 and 20, due to progressive neurological degeneration in CSA. CSB is even worse, with normal brain development halting immediately after birth, and the average lifespan is only about 2 to 7 years. Unfortunately, at this time, treatment is limited to supportive therapies such as physical therapy, occupational therapy, behavioral therapy, and speech therapy. Sometimes minor surgeries such as eye cataract removal are performed as well. Hearing aids can help improve quality of life, and special education is often necessary. All of these interventions and therapies are intended to improve quality of life and not to heal or cure the condition. Patients are consistently monitored throughout their life to update best therapy strategies as the disease progresses, and investigation into the effectiveness of potential gene therapies is underway and will hopefully be an option in the future. Finally, here are the references used to design this presentation. I hope this was an informative session and that you learned a little bit more about Cockayne syndrome. Thank you.